Dental, a BioLays webinar series. We're excited to welcome Teresa Duncan as our speaker. The lecture this evening is called Billing, Coding, and Revenue Tips for Today's Modern Dental Practice. As always, we are hosting tonight's webinar on the Zoom platform and welcome your questions during the lecture and the Q&A feature in the lower toolbar of your screen. Teresa and I were just chatting about that. So this topic typically creates a lot of good questions. So please don't be shy. And towards the end of the lecture, Teresa will proctor her own questions in that Q&A feature. So please make sure you utilize that. At the conclusion of the lecture and Q&A session, I'll provide information about BioLays Education CE process, along with additional web resources you can access to continue your learning journey in laser dentistry, including upcoming webinars and courses you may want to consider. So I'll give you some instructions on where to find our upcoming webinars, and if you're more interested in seminars or hands-on courses, I'll let you know where that you can find all of that. Our education portal is education.biolays.com, so please check that out. With that, let me formally introduce our speaker, Teresa Duncan. With over 20 years of healthcare experience, Teresa addresses topics such as insurance coding, office manager training, and patient conversations. Her memberships include the National Speakers Association and the National Association of Dental Plans. She has been named one of the top 25 women in dentistry as the author of Moving Your Patients to Yes, Easy Insurance Conversations, as well as a contributing author to the ADA's annual CDT Companion Guide. Her podcast, Nobody Told Me That, and Chew on This, provide regular coding and management updates. So, Teresa, it's so nice to have you back. I think it's been about a year and a half since we've had you on one of our national webinars. So nice to see your face and to have you with us.
Thank you.
I will pass it on to you.
All right, well, let's hit it then. And I actually recognized a few names in the chat. I actually gave a webinar earlier today for the ADA, and I see some of the same names in there. So thank you for hanging in there with me for another course on insurance. You guys are the dedicated ones. You will notice in the chat that I put a link to the handout, and that way you can download not just the PDF of the slides, but I've also got some information on staging and grading, which we'll talk about, and then also some procedures that require documentation. And so feel free to download that. I love it when people take the information from my classes and use them in their office and they become like the expert in their office. That's what I want. I want you all to be empowered enough to really make some good decisions about coding, about revenue in your own office. So you've got the link in there, and if you're not able to open it for some reason, just let me know. Either let myself or Joe know, and we'll make sure that you get the information. I want to make sure that you have it. We have a lot to talk about today. Oh, Joe, you know what we wanted to do? We wanted to see where everybody was from, because we like seeing how across the country we had a couple hundred people sign up. So wherever you're from, say hello and put the city or state that you're from. It's really fun to see where everybody is. I mean, look at the early one. Amanda's the first one with Boise, Idaho. Look at that. So lots and lots of people coming in. That tells me you all are interested to find out how to make this work. You all understand, most of you understand, especially the dentists who purchased the lasers, you understand how it makes you faster, how it makes you just a better and less painful dentist. The hard part, our pain, comes when we're trying to make sure that the ROI is there for the machine, any machine that you purchase, not just the laser. But I'll tell you, the ROI is there. Just having worked with so many offices over the years and talking to doctors who had purchased it, there's very rarely when I will hear a doctor say it's probably not the best decision I ever made. And if they do say that to me, it's usually because they're not really utilizing the laser. I don't think that's the problem with this group, because some of you are on the East Coast. It's 8 o'clock at night for me. I'm in Virginia, and you're sitting here at the end of your day wanting to learn more about that. So my goal today is to get you billing really well, to get you collecting really well, and to have good, effective conversations with your patients about insurance. Now, one issue that I hear all about is insurance is driving me crazy. Insurance, my patients, they think of nothing but insurance, insurance. They only want to do what insurance allows. Okay, I get that. So let's just go ahead and address the elephant in the room, the insurance elephant in the room, right? Let's go ahead and address that because yes, people are very insurance driven. I think that's just the nature of the industry and of the country. Most people, if they are told that they can get a good price, will tend to gravitate towards how they get that good price. And insurance is that way for many people. The fact is, though, we wouldn't get a lot of patients if they didn't have insurance. There's a lot of studies for that, right? Okay, so that's the pro for having insurance in our industry. The con, and I think probably many of you could fill this in, is that there's lots of guidelines that go along with it. There's documentation needs and all of that. And it can feel like we're being told the procedures that we've done in good faith and for the good of the patient is not necessary or is just, you're simply not going to get paid. What I'd like you to do is think of it a different way because Joe mentioned earlier, I work with the ADA, I'm very involved with them, very involved with the carriers as well. One of the organizations I belong to is the National Association of Dental Plans. I'm one of there's not too many provider representatives there, but they're there. And, we like to make sure that they know our point of view. The administrative burden on both sides is pretty high. Here's what I want you to know. If you are coming at it with the mindset of, oh gosh, insurance is making my life miserable, then it's going to make your life miserable. What I want you to do is think of insurance as the tool to get the patients in your office, because when you are a participating provider, that's really what that means. All right. So what I don't like, though, is the fact that there is more administrative burden over the years than there ever was. When I first started, close to 30 years, I mean, maybe even 30 years ago, when I first started, we barely had the administrative burden that we have now. It was a fraction. And it has really evolved, and it's evolved slowly. I sometimes feel like I've been a frog in boiling water, and I'm just now looking around and saying, holy cow, look at all this stuff that I need to submit. When I said to you that it feels like insurance is making decisions about the treatment and saying that you shouldn't have done that, every carrier that I've ever talked to has said to me, that's not it. We don't, you know what, we're not supposed to get in the middle of that. I mean, it looks like it, but they're not supposed to be in the middle of that. And I see their point. What they're doing is making a benefit determination, and that is coming directly from the employer. I have some language for you about that towards the end where we can have good conversations about our patients with that. But I don't want you, if you have a denial, I don't want you to think, well, they're questioning my skills. They're not questioning your skills. They're questioning the benefit. And the role of insurance is to maximize shareholder profit, but also to provide quality care to their subscriber. Their client is the employer and the subscriber. That really is the primary client. You're a partner, they're the primary client. I'm giving you a big level view because I would love for us to take the animosity down a notch, because I think what I've seen, what I've definitely seen over the years is a dentists making decisions based mostly on emotion, and they end up being wrong decisions. They end up being ill-timed decisions. I don't want that for you all. So definitely look at it with a level head. If you're constantly getting denials, we need to look, what is your documentation like? Could it be that we could spruce that up a little bit? Now, we're going to talk about billing tips. We're going to talk about revenue, insurance tips. All of that has to do with getting paid. So if I were to walk into your office and the first thing you say to me is, I'm having so much trouble with insurance, I'm appealing everything, nothing comes back, my claims go out and they come right back in for missing information, I have to really take a look at that. In my experience, many offices think they're sending out clean claims, but they're not. Maybe there's a couple tweaks. So you're going to see a lot of documentation tips throughout this, and documentation is 100% tied to your revenue. And that's what I say in many of my classes. It almost becomes a mantra. Your documentation will drive your revenue. If you don't have good documentation, I may be the best insurance coordinator you've ever met in your life, but if your documentation is terrible, I can't get your claim paid, right? So that's where I'm appealing to you to take a look at the documentation and clinical information that I'm going to give to you. Keeping in mind, I am not a clinician. I was an assistant for a hot minute, and my boss graciously said, maybe you should be up front. So that tells you how good of an assistant I was. but I know a lot about procedures, but you are the clinician, the dentists who are listening, you are the clinician. And I want to urge you that everything that you write down and every action you take, as if the pressure isn't there, that's your license on the line. So be good with your documentation. If you ever get pulled into a court of law, there is no judge that's going to say, okay, well, I guess, yeah, you had a rough day that day. I get it. That's why you didn't document anything. Okay, let's just dismiss the case. That's never going to happen. So let's make sure that our documentation is really just foolproof. So your clinical notes should be as complete as possible and also completed as soon as possible. I know lots of malpractice attorneys. I keep in regular contact with a bunch of them. And there's a few that have told me straight up, I'm nervous when my doctors do not finish clinical notes the day of the appointment. A day, 24 hours, okay, we'll give them some grace. But longer than that, there's some doubt that can be cast because how can you remember everything if there's a day that goes by? And I'm here to tell you the older you get, the worse it is. I'm sure that some of you are dealing with that. The industry as a whole is moving away from narratives, and they are looking for screenshots of your clinical notes. As an insurance coordinator, I'm very excited about this because that means I don't have to write these narratives. Even though I was really good at it, I don't have to write them anymore. I just need to screenshot your clinical notes as an attachment, and that's going to be what gets the claim across the finish line. But I need to make sure that your notes are good. When I say this in my classes, my live classes, I can look around the room and I will say this and I can see the administrators going, oh, well, that's nice if you can do it, but I can't because my doctor doesn't have great notes. That's that's where we can start. So tomorrow's Friday. Maybe hopefully it's a little bit slower at your office and you can take a look at your clinical notes and see if they're up to speed. They are looking for, and so is your malpractice attorney, looking for clear and current intraoral images and radiographs. So the rule of thumb is that perio charting and intraoral images and radiographs are all set. They all need to be within 1 to 2 years old. So even if you send them a super clear radiograph from 3 years ago, it's not enough. So what I would love for you to do is to make sure that you are labeling your notes when your clinical images when you're sending them in, making sure they're very, very clear. We're going to talk about AI for a little bit, and I'll go over the intraoral images with that. But they need to be very current and they need to be really good. So I will just say this as gently as I can. If you have somebody in your office who is really terrible at taking x-rays, there's open bites, cone cuts, overlaps, all of the fun stuff that can happen with images, that's not going to cut it anymore. And then, so forget insurance. This is your license, right? So how are you supposed to make a diagnosis off of a bad quality radiograph? And that's exactly that's the question that's going to come up. And I just see a funny joke in the chat. I shouldn't have looked over, but I can't help it. U of Pacific graduate wants to know if masks are required for this webinar. Well, I'm not breathing on you, so you can take your chances without a mask, right? All right. So if you have previous treatment that has been provided by the patient, that's great. It becomes part of your clinical notes. You can scan it, and now we can go ahead and take a screenshot of that too. But if you don't get previous notes, please put that in the chart. Patient requested that patient get us a copy of the previous notes. Patient was advised that they need to have that for their comprehensive evaluation. The day of the comprehensive evaluation, you write down patient was not able to get a copy of their clinical notes. And that's helpful because sometimes we do need a history of procedures. But if you don't have it, you don't have it. But it needs to be documented somewhere that you were not able to obtain those clinical notes from a previous dentist. So I hope that makes a lot of sense for you. And we're going to go over as well, to me, the best place where you can gather some of this documentation. So what you're doing with these laser procedures are pretty advanced procedures. You know, they will need the soap notes. They will need a prescription. What kind of, not a written prescription like Tylenol or whatever. I'm talking about a prescription based on a diagnosis. What is the treatment plan for these particular teeth or surfaces or areas that you're going to work on? When the patient comes in for their evaluation, whether it's a new patient, whether it's the periodic evaluation, this is the best time to record most of the diagnosis that I need and also existing conditions. There are many, many times when we'll work with when I used to go in office, we would look for this and it was usually never there. But the people that I'm coaching on the side, what they're doing is they are making sure that the comprehensive evaluation, the first evaluation, has all sorts of things like missing teeth, if the crown needs to be replaced, why, what's the reason, and it goes into the clinical notes for that particular visit. So when you come in later, when the patient comes in later and I need to submit my clinical notes, I'm going to take a copy of the today's clinical notes with the information on what you did, what were the services you provided, and all of the SOAP notes that go with it. And then I'm going to scoot back to the comprehensive evaluation date, and I'm going to take a screenshot of that clinical note too that shows all of the existing conditions, any of the statements that the patient made. A lot of times patients come in and say something, and you're writing in there, patient states that tooth on upper left side has been feeling bad. She feels like it's cracked. Put it in quotes. Patient tastes has a strange taste in the back of the mouth. That's what I'm looking for. I need information like that from the comprehensive evaluation or the periodontal evaluation. If you don't have templates, this is a good time to get them. And I'm just going to put a push in there. Most of us have gone digital for as far as clinical notes. And maybe 5 years ago, 7 years ago, I would have said, oh, why aren't you using templates? Okay, well, you're still getting used to it. So let's see if we can get that fixed. If you're on digital and you still haven't set up your templates, I would love to assign some homework to you, because not only is it going to make your life easier, it's going to make your team a better record keeper for you. The trick with templates, and here's what I have been told directly from the insurance carriers, is yes, the templates are great. They're organized. They can find the information very quickly. But what they have noticed is sometimes we get really lazy with templates where we don't actually change a lot. We kind of go, oh, that looks the same. Or we go, that was the same procedure. There's not much change. I'm just going to leave it. That note's fine as it is. But there should be some sort of distinguishing remark, either a statement made by the patient. There's no mouth that's the same. You all know that, right? So the problem that carriers are identifying is that if you use templates and you use the same template over and over again, that's going to get you flagged. And in a court of law, that's going to get you into a lot of trouble. Your malpractice attorney is not going to be happy when he or she goes to review your clinical notes. So remember, I was talking about some time limitations. The radiographs, basically, you have usually up to 2 years to have a current radiograph. So you should, and if you're seeing a patient regularly, if you're seeing a patient on a new patient basis, you're going to have regular radiographs within 2 years. So that's pretty normal. I have seen some plans where they are making benefit decisions and they require the radiographs to be within 1 year. And that's the thing that I want you to think about. When we have these limitations in the coverage booklets, what we're seeing, so say it's 12 months for an x-ray, it's not saying that you can't do the procedure. What it's saying is if they cannot make a benefit decision, not a treatment decision, a benefit decision based on documentation that doesn't meet their criteria. So if you're sending old x-rays, then they just can't. They have to deny it because of that. Even if it's like a 2-day miss, they have to adhere to the guidelines that they are, their insurance has a lot more regulations than we do. I know it doesn't seem like it, but they do. I also would love for you or your assistant to make sure you're recording the missing teeth in the software. I'm always surprised by how many people don't do that. And when we go to print out a perio chart, there's no numbers around a tooth, but yet no one has marked that tooth missing. Very strange to me, right? And then intraoral images. I think we are at a point now that I think we are actually doing lots of intraoral images. When I first started lecturing on insurance a very long time ago, having a dentist that took intraoral images was amazing. But I think most of you have moved to that. And it's a good documentation tool. Could be diagnostic, but really a good documentation tool. Really good for treatment plan presentation too. As a treatment plan coordinator for years and years, I always leaned on models like what you see on the screen. And I know it looks old school. And some of you are like, wow, that looks archaic. I am telling you, I closed so many cases with models like that because they are so easy for a patient to visualize. When you say to them, hey, look at that x ray up on the screen, they just see shades of gray and white. They don't see what I want them to see. And that's why going visual with your models and your education is absolutely the way to go. Okay, so let's move on then to a laser specific scenario here. So this is the repair perio protocol. And for those of you that already own a laser from BioLase, you have seen this. It's in your documentation. There is a coding guide that's out there. We are in the process of revamping that and updating that, but this is all throughout the documentation for that. And then also for the clinical information that you get from the sales rep. So you have the different phases here and the treatment. And what I did is I went through and added in the procedure codes that could accompany that particular scenario. And remember, don't worry about trying to write all this down and scribble. You do have in the chat, you will have the ability to go and download a PDF of all the slides so that you can then study them at a later time. So there's an awful lot of things that we can do pre-surgical, right? Before we do any perio treatment, you've got an evaluation, you got all these radiographs. Some of you are taking 3D intraoral images on the tomosynth. Oh gosh, I can never say it right. It's a tomosynthesis something, but basically that you guys are taking all sorts of X-rays, which is great. So the unfortunate piece, though, is that there's so many imaging codes now. That's why I really believe that you should once a year, every year, actually, put it in your budget to buy a new copy of the CDT code book and the coding companion. They bundle it. It comes in an app. Many of the insurance coordinators that I know, they have this on their chair side. This is like their Bible. You guys, I don't know what you have in the back as your Bible, but we do. I always have mine nearby because I get all sorts of coding questions. So make sure that you put that in the budget. So then you have the surgical phase, and I gave you some codes for that. And then, of course, you've got the post-surgical phase. I want to point out one here, which is 171. So this code is, to me, not used often enough. And to me, this is a very great code. I love these codes. There are codes out there that I cannot stand. I don't like using them. They're so problematic. You all know what I'm talking about, my admin people. There's codes that you just see come across and you're like, oh gosh, this is going to be an uphill battle. 171 is one of those that I wish I saw more of. 171 is a reevaluation visit after performing a procedure. And it really is meant for procedures like scaling and root planing, osseous surgery, if you're doing any kind of grafting and you get them to come back in and do an evaluation. 171 is that. Come back in, let's evaluate it. It's a post-surgical, post-procedure evaluation. Yes, it does go against the two evaluations that the patient will usually have from insurance, but I'm going to be real blunt here. That's not my problem. That's the patient's evaluation fee. But it's not my problem because during the treatment plan presentation, we made sure that they were aware that this was going to be an evaluation. And it looks like your employer selected a plan, Mrs. Jones, that only covers 2 evaluations. But because of the treatment we're doing, you may need 3 or 4 different evaluations for the year. So I'm just giving you a heads up that there might be some out of pocket for that. And if you notice what I did, I really was putting the blame not necessarily on me, because I'm not the one who chose the plan. I'm pointing out that it is a restriction on the plan that their employer purchased, and we're going to talk a little bit about that towards the end. But I kind of snuck that in as a little bit of a spoiler for how I'm going to go over those conversations with the patient. And here is just a long list here. I'm not going to read through all of these, but this is your documentation for the periodontal laser usage. And so this was totally this was come up by BioLase. Like basically everything should be in there. And if you are going to write your clinical templates or create your clinical templates, I think it's super smart to use one that's already been given to you. And they've been giving this to dentists who use their lasers for years. So feel free to use that. What you do is you create the template. And then if you don't need anything on there, then you just back out the template. And of course, you want to make sure that you customize it. Patient made these statements. Maybe you saw something specific to that patient's anatomy. You want to make sure you make a note of it. That's how clinical templates should be used. Okay, so definitely not going to go through all of that because we'll be here all night, right? One topic that we have in our classes all the time, I'm always asking, what's your least favorite code? And without a doubt, the two that lead the pack are 4341. Okay, so that's your scaling and root planing, and then crown buildup. It's always scaling and root planing and crown buildup. I just don't hear any others. Those are the biggest voices in there. When it comes to perio, if you're thinking to yourself, yeah, perio seems a lot harder than it used to. If you're in network, I bet you're right. I bet you're right because it is unfortunately it's an overutilized code, and there are some bad players out there in the market that will see a patient for a new patient exam, and then they're all of a sudden everybody is scaling and replaning. You all probably know the people in your area that do that. I hear about it all the time, so I know it happens. It's really sad, but because of that, we all end up being over scrutinized, right? And then a lot of the guidelines have changed to have, I don't know, 30 millimeter pockets before they do scale, before they approve benefits for it, right? That's what it feels like sometimes. But the guidelines are the guidelines. And so it might be 5 millimeters, 6 millimeter. Let's just say you ran into a plan, it's a 6 millimeter guideline for bone loss, and anything under that is not going to have scaling and root planing or any kind of periodontal treatment approved for that. That is where I'm going to definitely phrase to the patient that I'm very surprised about this. Most plans that we work with, Mrs. Jones, actually do have coverage for that. Their employer selected that. I'm surprised your employer didn't select it. Maybe they just didn't know that it was available. I'm happy to talk to your employer about it, your HR department. Maybe I can help them fix that. I bet it's not going to be hard. That is exactly what I would say to the patient about the fact that their plan is not allowing benefits. So I want you to make sure that you're changing in your conversations too. You know, a lot of people are saying, "Oh, it's not covered, and insurance denied it, and insurance denied that." I would love you to be more specific in your conversations with your patients. It's not that the insurance company says we shouldn't have done it, Mrs. Jones. It just looks like they can't approve benefits for it, and that's a relationship between the carrier and your employer. So I'm going to put the focus where it should be, which is on the plan design that you and I had absolutely nothing to do with. So why am I talking about plan design? And there's a big old slide on periodontitis staging, and coming up is grading. I was going over this because when we talk about perio claims in my class, I always ask, are any of you doing the staging and the grading in your office? And are you documenting that? And is it in your clinical notes? And I'm sad to say that it's probably, I would say, three-quarters of the room, maybe even a little bit more, are not utilizing staging and grading. They are still classifying periodontal disease using the old method. I want you all to be using this method. I want every comprehensive evaluation to have some sort of stage attached. Is a patient stage 1, stage 2, stage 3? We could talk a lot about all of this. I think this is a tool that we need to really embrace. So the staging would be in the notes. And now when we talk about the rate of healing, so many of you are trying to get your 4910s covered, but they only are going to allow benefits for them for 2 years out from the last scaling and root planing. That's a common clause. So if the patient is at a grade C, that disease is still trucking along, home care is almost non-existent, it's just a mess in there, they're not getting better, that's a good case for you to make in your appeal, saying that the patient has been at a grade C, 4910 is needed to continue to provide treatment for the patient. And I know some of you are like, wow, if they're grade C for a while, I'm redoing everything. This is where it's good that I'm not clinical, right? So that's up to you. That's your clinical call. But I'm going to try to get those 4910s paid with appeal. Speaking honestly, I used to be able to get it covered all of the time, saying, you know, at least can I have the alternate benefit of a pro fee? It's harder and harder to do that now. I would say I'm probably 50-50 on that. And I just don't want you to get your hopes up. But that is, again, part of the conversation I'm going to have with the patient. Okay, so with all of this being said, when you have the staging where the patient came into your office, how they presented to you, this is now that we have, maybe you have patients that have more than 5 millimeter probing depth, horizontal bone loss, and we are looking at stage 2. Okay. So it's actually the max is less than 5 millimeters. If we go over here to stage 3 and stage 4, now we have probing depths of over 5 millimeters, and then some additional factors in there. So also taking into account risk factors, taking into account structural issues, mastication, all of that kind of stuff, the anatomical issues that you might be faced with. You might also have a patient that just has terrible home care, smokes, whatever it is that they're doing nowadays. You could then, by saying stage 4, you have now put them into a recognized disease state. And I can tell you, carriers do like to see that. And one thing that I was told was, I can't believe I don't see this very often. I think this is standard of care, which it is. And your lawyer is going to be telling you what the standard of care. So if you're not doing staging and grading, please do. And it's probably worth having a really good conversation with the rest of your team on it. What I find is many people will come up to me afterwards, after a class, and say, I was totally lost during that whole thing. And that's why I do a little bit of time explaining it. These 2 slides are actually in the handout in that folder, the link that I gave you, so that you can print these out. But you can also go to perio.org, which is the American Academy of Periodontology site, and you can look for the new classifications. They were back in 2019. So they've been around a while. Actually, I think 2017. Now I'm trying to remember. They've been around a while. So there's really no excuse to not have these in your clinical notes now. Then the question always comes, well, where am I supposed to put that in the clinical notes? Because this is a newer classification, right? Newish. So feel free to steal this. And again, it's in the PDF of the slides. Patient presents with stage according to the current AAP guidelines, and visible signs include, assistant can fill that out. You can fill that out. Radiographs and images show. And then this is where you're going to discuss the periodontal involvement. All right. So periodontal maintenance and continuing care visits, now they're coming back in for their regular appointments. You are now in charge of grading the disease process. And that is where you're going to write that here. Patient shows, tell what time of healing it is, since the initial setting of the stage, currently presents as grade. And hopefully it's not C, but sometimes patients don't do what we ask. I know you're shocked to hear that. So feel free to use that template. I want you to. So a couple of things about scaling and root planing. Definitely, you see a lot of 24 or 36 month frequency limitations on per quadrant, per patient, and I'm sorry, per quadrant, per plan. Sometimes if the patient changes insurance companies, then you're not going to run into that again if they're not talking to each other. But typically that is the frequency limitation on scaling and root planing. That's 43, 41, 43, 42. But also your osteosurgery usually follows that same timeline. They are always going to want periodontal charting. And I'm going to give you the super easy way of looking at it. I need it to be very colorful. I need it to show bleeding upon the bleeding points. I need to show furcation. I need recession. I need all of the stuff that makes it light up like a rainbow. I've sat in on multiple over the years claim reviews that the dental consultants for the carriers actually attend, and they look at it and they kind of talk it out and see how they would have approved benefits or what they wouldn't have. And I'm always so surprised by the poor quality of the radiographs, but also surprised by perio charting that has no bleeding points on there. There's just a couple numbers scattered here and there. We can do better, and we should do better. The patient deserves it, but your license is hoping that they can stay on your wall, because you need good documentation to keep that license if it were to ever be caught up. I don't know if you ever take a look at your state board and the minutes from there. I'm in Virginia. I sign up for alerts on the state board. I see a lot of dentists having to retake classes specifically on billing and coding, and also on just clinical situations. But there are a lot of them out there that are being told to go through coding and billing classes specifically. And it has to do with the documentation piece. Okay, what I'd also like you to do is note the seat and dismissal time of the patient. So that has to do more with, we have been seeing a lot of audits come about where the patient is, the carrier sees that you're doing like maybe 15 patients in one day and it's all scaling and root planing, and then their little alarm bells go off. You're going to get flagged. Sometimes they will and this is happening. They will ask for a copy of your schedule. They basically want to see if you actually saw the patient and did the stuff um, that you are claiming to have done, that you billed for. So I would rather you just put that in your notes anyways. To me, that's part of the electronic health record. That's part of good notes there. And if you're doing same day crowns, this is essential too, because you can say patient was here for the whole, 2, 3 hours, however long it takes, and crown was delivered. So I'm a big proponent now of adding noting seat and dismissal times in there. So just a quick tip about radiographs before we move into some other codes. The patient really can see this pop out really well. And as a treatment coordinator, I wish I had AI images back in my office. Goodness, it would have been amazing. We would have closed even more cases than we already closed, right? So if you are going to send in images for documentation, please make sure that you are sending in the original unaltered image, that you can see the one on the side without the colors. Then you can send in the altered image, the annotated image that shows where there are areas of concern. But I definitely, taking insurance out of it, forget about insurance for a second. This is going to help me have really good conversations with my patients. I don't have to hope that they see the strange shading that it is very obvious to me, but is never obvious to them. I had one patient tell me, the horns in the molar, the shadow there. She said, well, why are you telling me I need to treat this? I've got a lot of decay right there in the middle of the tooth. And it's because she didn't know anatomy. And I wonder how many other patients were looking at me like, why aren't you taking care of that black dot? Right. Lots and lots to think about when you look at tackling treatment presentation with good visual images. They also, if you tell them, remember how I said ahead of time, I'm going to give them a heads up that it's kind of difficult to get cleaning, scaling, and root planing covered than it used to be. It's a little bit more difficult, but I'll definitely do everything I can, Mrs. Jones. But look at these x-rays, Mrs. Jones. You can see that you clearly need the work. And of course, we're talking about crowns here. But when I call Mrs. Jones and I say, look, I can't get this appeal paid, I'm having a hard time, she's more likely to come up and really advocate for their own benefits because they see it, they buy into it. And this to me is really just nailing that trust issue. The patient doesn't see this. They sometimes nothing hurts, right? This is really telling them that there are things going on in there. You look a little high tech. That's always nice. You always look like the new technology on the block, right? That's fun. But for a case presentation and financial presentations, I really wish that I'd had this. I'm kind of sad I missed out on that golden age of documentation. So I wanted to show you, let's get into some laser information here. This is from the 2024 Delta Dental Handbook. And I wanted to give you, this is from the periodontal section. That very first one, laser disinfection is a technique and not a procedure. Fees for laser disinfection are not billable to the patient. So the general Delta Dental Handbook does state that. And so and I've attended the ADA coding meetings, I don't know, it might be up to 8 or 9 years now. Laser has never been welcomed as a acceptable new code addition. So that's why we don't have any laser code specific to the machine that you bought or are considering buying. They are saying that it's just the same thing as doing endo with hand files, or if you're using rotary, right? It doesn't matter to them. The procedure is it matters to them. Now that stinks for us. It really does, because we're doing a separate procedure. To me, LBR, laser bacterial reduction, is a separate procedure. And we now have, the only thing that we have is 4999 in our arsenal. That's the miscellaneous code. But you can see Delta, and I can tell you most of the carriers, they also consider this to be the same. Look at the next one. Standalone procedure, lasers for disinfection, is denied as investigational. That's a kind of a hard word to read when you've been in the industry long enough and you see how well the laser performs. I'm not clinical, and I can see before and after. I've talked to patients in my old office that have had laser treatment. It's great. It does work, but to be called investigational kind of is an ouch, I think. Benefits for biostimulation are denied as investigational. Some of you are using, if you don't know what that is and you're not using it, that's fine. Talk to your rep about it. But right now, it's going to be denied as investigational. And so I'm really looking through all of this, And I'm saying, wow, they really are going out of their way to tell us that laser is not going to be covered. And that's the feeling I get. I've been doing this a long time. I don't I don't see this changing for I just don't think that this is changing until time marches on and it becomes something that is so ubiquitous. The fact is, this is being taught in dental schools, you're being DSOs, big corporations take this up. I think if anything changes with the code, it's going to be from the DSO side, who's going to push for it because they have such a large volume. It's sort of disappointing to me, but the code maintenance committee has their rules for a reason, and they just don't see it. Once we just need someone to make them see it, right? Okay, so let's keep going here. So LBR, yeah, there is no code that accurately describes this. And so that's what's frustrating about when it says that it is going to, so I'll just read it here. It's a technique, not a procedure. However, we do, there are, it's more than a technique. It's definitely a procedure. It's separate. You can do scaling and root planing without the LBR, right? To me, it is a different procedure. But again, I'm not a clinician, so I respect the decisions that are made about this by clinicians. It is almost always going to be bundled up with another procedure. Now, if you are out of network, then you don't care because you can bill the patient and life is easy and life is great. But if you're in network, then you're thinking, I've got this machine and I need to pay for it. So that is the wrong attitude. And it's hard for me to say that because I never want to be forceful about something. I respect all of your rationales behind these feelings because I've talked to too many of you. So I know there's some valid concern there. But if you are buying a laser thinking you're going to make money because of the coding, that's not going to happen. Where the ROI comes in is you're faster, your patient's not having pain, you are going to be faster and better at the procedures the more that you do. Pain-free dentistry is a real thing. So you're going to become more efficient and faster. And if there's anything I've learned in my long years when it comes to the turnover in an office, I'm talking about turning over a room, you can't bill in a room that's being occupied for an awful long time. You can't bill what you need to. So if you're faster, you can bill more because you've got another person in. So another patient in the chair. So I'm hoping that this can make you a faster clinician after the learning curve, be a faster clinician, and that's where you're going to realize the benefits of it. And if you're doing any cosmetic procedures with it, then that kind of marketing takes care of itself. So that's a whole different conversation here. What about this form? I see in the forums, I see on all sorts of dental groups that, well, I just have them sign a form and then I'm able to charge them my full fee. If you have signed a contract and in your provider policy, your handbook, which is why I gave you that straight from the Delta handbook, you are in a situation where you've agreed to not charge for this. And that's a hard pill to swallow. It is. But until you make the decision to not be beholden to that contract, you agreed to it. And that's the unfortunate piece. Now, if you do want to have the patient use what we call a HIPAA form, a right to restrict disclosure form, you can use that, but there's some real sticking points around it. So let me back up a second. The patient comes in, scaling and root planing. You want to do LBR. All right. So you're thinking to yourself, I'm going to bill the scaling and root planing, but I'm going to not bill the LBR to the insurance company because I'm going to have a patient sign that they understand that this is out of pocket. So that is a misuse of the form right there. If you are interested, I'm happy to send you a resource. There's the Dental Billing Academy has good resources on this and a sample along with instructions. That's a Facebook group. Rick Garofalo is the owner of that group, and he has it on his website, an example. But what I want you to think about is this. When you use the right to restrict disclosure form, it is every procedure that day. You don't get to pick and choose. It's every procedure that day. And you must collect your full fee on these procedures because by signing that form, there is no insurance involvement at all. So now you're back to charging the patient the full fee. It's very hard to tell a patient to sign a form that lets you charge more than they needed to pay. That's the rub. That's the hard part. So if you are going to use that form and you're like, oh, I'm just going to do, you know what? All my friends are getting away with it. I'm going to do it this way. Just know that it can be revoked at any time. A good friend of mine who's also a coding instructor, she was just telling me that she had a client who was doing this and saying, well, everybody's telling me they never get audited, nothing happens. And they had a large insurance company. I believe, I want to say it was MetLife, but I don't want to say that for sure. It could have been another one. Basically, they came in, saw that he was misusing the HIPAA release form, and they terminated the contract right away. So I hope that person wanted to go out of network, because that was kind of what happened after that, right? Okay, so let's keep going because we have a lot of codes to go through. So I'm giving you the osseous surgery here. And some of these codes we're not going to spend a ton of time on, only because you've got everything you need right there. So change your clinical templates to have this as a clinical note, and if it doesn't apply, then back it out. Don't send it in just because you think it's going to get it covered. It has to actually apply, right? So the code states that bone has to be augmented or removed for osseous surgery. So in your notes, you want to write down how many millimeters of bone was removed. Where was the bone removed? That's the documentation for osseous surgery. You're going to see a little circle on some of these procedures that says medical billing. Some of the ones that I have marked like that, there are ways to obtain medical billing, medical payment for that. But I'm happy to send you resources on that. Please don't call me on it. I am not a medical billing expert, and I don't want to be in the business of teaching people to do medical billing, because I'm sure I'll tell you something wrong. However, there are procedures that we do on a regular basis that are billable to the medical side of the patient's benefits. All right, so gingivectomies, we see a lot, all right? And you're doing these and you're getting fast at them, right? Now, if you're out of network, great. So no worries there. But I have seen definitely gingivectomies get bundled up with the crown buildup and crown. I do appeal almost everything. I mean, really everything. And I still do claims for my old dentist. He won't let me stop. But basically, we appeal everything, even if if I suspect it's a hard wired containment clause, I am still going to do the appeal. I want the patient to see that we tried our best to get coverage, but you never know. You never know what could happen. Sometimes you get somebody who says, yeah, that gingivectomy, yeah, we're not going to cover it, but it's not going to be bundled up. You can bill at least the PPO fee. So I say give it a shot. And again, my mantra: documentation is going to drive your revenue. Appeal everything. Appeal everything. All right, so you have crown exposure here, and I like to sprinkle in a little bit of history. This is a caveman's jaw, and so it basically, I don't know, it's real interesting to me, right? Like, that's just cool. 14,000 years old, teeth still going along there. Well, some of them anyways. So for the crown exposure, typically it's not going to be reimbursed as the same day as the restorative procedure. Our frustration comes into play because why do we get the patient to come back in twice? That doesn't make any sense. But that's how the benefit is written. Now, if I am able to talk to the HR department, I'm going to explain that this is just not what's done. There's no clinical reason to bring them back on a separate day to do this procedure. It's just a cost containment clause that your carrier has in place. Maybe you could change that the next time. And carriers will change the makeup of the plan in response to the employer, because they want to keep that company as a paying entity. I get it. So there are the codes for that. I always, anytime that it's something that I suspect is going to get me to have to do an appeal, or I know it's going to be problematic, I always prepare the patient. Mrs. Jones, we're going to do everything we can to get that appeal taken care of. We'll do everything. Don't worry about it. We will send in the documentations and all of that. But I just need to let you know that if for some reason they do not cover it, we'll need to come back to you and have you take care of your portion. That's suddenly when patients kind of wake up. When you say, hey, remember when I said you might have to have an out of pocket? You suddenly will get your phone calls returned. It's funny how that works, right? Okay, so let's talk about crown lengthening here. The necessary documentation, it's pretty easy, but clinical crown lengthening is typically bundled up as well. The plan is the patient's plan is going to be very specific on whether or not they pay it on the same day as the restoration. So often I see that there are benefits for crown lengthening, but on a different day. That's not fun, right? So I wanted to just call out this here. The third bullet point must include alveolar bone recontouring. I've seen that in multiple manuals, so I'm comfortable telling you put that in the template, and then of course back it out if that does not fit the bill. But I want to just underline that part of the code down there, it requires a reflection of the full thickness flap and removal of bone, which is why I'm asking for documentation of bone, that bone has been removed, that there has actually been a flap that has been exposed. And this is also in a healthy periodontal environment. So definitely, if you send in radiographs and there's all sorts of bone loss and you're claiming for clinical crown lengthening, they're not going to cover it. And that's because it's specifically in there. It's in the code there. Okay, so let's talk about these two, the frenectomies and frenuloplasty. We had if you're working off 7960, just know that that's an old code. Make sure that you are current with your codes. Once a year, January, the codes do change, and so you need to be able to have accurate codes, right? That's going to get a claim stopped pretty quickly. So there's your codes for the frenectomies. Goes by surfaces now, because as I understand, you can definitely have just more than one surface done for a frenectomy. And so I think this is a good thing that they were able to add in the multiple surfaces to more accurately describe the procedure that you're doing. Did it interfere with proper oral home care? Does it interfere with the seating of a prosthetic? These are all things that I want you to have in your clinical notes, because if that applies, I want you to be able to use it. That helps it. The coverage available, and then the bullet points. I don't come up with these. I have spent lots of time every year poring over provider processing manuals and finding what they usually will reimburse for. And so a lot of these bullet points come directly from those. And again, look at the follow-up evaluation. If you're getting them back to make sure that healing is okay after one of these procedures, 171 is the appropriate code. I would love to assign more homework that basically is going to tell you you are not allowed. Here's my homework for you. Take it with a grain of salt, but I'm sort of serious. You are not allowed anymore to have free appointments, look-see appointments. We're just going to check appointments. Your overhead doesn't go away. You don't pause your overhead. You don't pause the cost of your supplies. When you do that procedure, there is overhead and there's chair time, supplies, disposable, all of that. So I don't want you to get in the habit of doing a lot of free looks after you do a procedure. Okay, let's keep going here. I do see some questions. It's great. Good crowd here that wants to have some answers. We'll get to them. Okay, for biopsies and excisions, again, not reimbursed on the same day as restorative procedure. Anytime that came into play, I always was explaining to the patient, for some strange reason, your employer wants you to take off work and come in 2 separate times. I don't know if they know that. And that's how I would say it. That's how I would say it with the crown buildup and crown. For some reason, they're going to cover it if you don't come in, if you come in on 2 separate days. Excuse me, Mrs. Jones, that makes absolutely no sense to me. I'm sure they don't want you taking time off of work. I apologize. Okay, so you've got here also the ability to bill to medical for biopsies and excisions. In fact, they're very easy to bill to biopsies. To bill to medical. You just have to make sure you have your ICD-10 code, your diagnosis codes, and all of that. But again, not a medical billing expert. Seek help from somebody else. I'll send you to who I really like, but seek help. Typically denied these procedures here. I'm just going to tell you that I have appealed tori removal multiple times, and it's been very hard to get. So I really I don't know what it takes to get that covered. So, and then across the board in all of these provider manuals, these are the codes that honestly had no coverage. And so there was just always not covered. So I just wanted, and of course this applies to your purchase. I wanted to make sure that you were aware that these are a little bit harder to get taken care of. Tori removal definitely could be a medical procedure if the patient has that kind of benefits. So again, another use case for that. So let me go here to our insurance conversations, and then we are kind of in the home stretch here. This is kind of fun. The insurance conversations that you're going to have here, and this is a picture here. I want you to look at this picture of the woman. This is a rare sighting of a patient actually reading their EOB. From This is insurance administrator humor here. We know patients don't read their explanation of benefits, their EOBs. Anytime I've ever asked a patient, "Did you read your EOB?" They're like, "I don't even know what that is, Teresa." They don't read them. They don't understand it. They're written in Greek. Only people who have taken dental claim ease are able to translate these EOBs here. So I need to make sure that we are communicating about possible denials, about plan design to the patient. We need to be the ones communicating that. I'm always going to be very transparent about how much it will cost if there's no insurance involvement. So, Mrs. Jones, the price of the treatment that doctor is recommending is $3,000. We're going to try to obtain as much of your benefits as possible, but just know if your insurance company is restricted by the plan and isn't able to pay out for some reason, we're going to need to come back to you. So and definitely maybe you can help us. Maybe you can help us call the insurance carrier or call your employer. But those are the conversations I'm going to have with the patient. I want them to know that I am in their corner. So some other firm messaging that I want you to have. And again, this is part of the homework I'm giving you to really put the focus on where it needs to be. Mrs. Jones, your plan doesn't cover crown lengthening. It looks like your employer selected a plan that doesn't cover that. I'm really sorry. We typically see coverage for that, but it looks like your employer opted to leave that out. I'm sorry that there's no it looks like your plan doesn't cover adult ortho. I'm surprised. We have a lot of offices, I'm sorry, a lot of carriers that do allow for adult ortho. We have a ton of adult ortho patients who get this covered. Maybe you could talk to your HR and see what the price difference is, and maybe they could get that onto the plan. This is how we affect change from our side. This is how we affect change by making sure the patient understands we didn't choose these benefits. These are your benefits. More importantly, these are your employer's benefits, and that they've chosen. So let's put the focus where it needs to be. I'm going to do everything I can, Mrs. Jones, to make sure that you get payment. I'm going to send the appeal in. I'm going to send in all the documentation. But in the end, if I can't get anything covered, unfortunately, I'm going to come back to you, and we'll talk about that. Now, let's talk about cash flow for a hot second before we get into winding down here. I would love for you, as a best practice, to if you're out of network and you've decided that you're going to collect everything and just file the claim as a courtesy. This is not meant for you. You're obviously collecting everything already, so hats off to you. But for those of you that are accepting assignment of benefits, and that usually we do that to lessen the burden on the patient, the financial burden on the patient. So here's what I'll say to collecting the estimates here. Anytime I say it's going to be, $500 is going to be your out of pocket, Mrs. Jones, that's my best estimate. I never use words like it will be this, because anytime I say that, it ends up not being accurate. So it will be, this is my best guess for it. I know that there are offices out there who are over collecting because they feel that it's nicer to write a refund check than it is to go chase a patient. I can't argue with it's nicer to write a refund than to chase the patient. But if you're in an in-network your provider contract that you sign states that you are obligated to attempt to collect the patient's portion, not more. And so I worry that you're going to get into hot water by over collecting and then not refunding quickly. I'm getting a lot of questions about that in email, so I don't know where that's really coming from, but I'm concerned that it's going to get some people into hot water. We are obligated to attempt to collect what we think is the patient's out of pocket. If you're in network, we're not collecting the full amount is not that's not what the contract is calling for. So be careful. And that's really what I want to get across is there is a way to make laser procedures. And in fact, any of the new modalities out there, if you're doing same day crowns, there is a way to make it profitable, but I also want you to not get audited. And I hear all the time, well, I've never been audited. Well, that's what everybody who's been audited used to say, and they can't say that anymore. So I don't want that to happen to you. My job as an office manager, when I was in the office all day with my old boss, my job was to protect the practice and to protect my doctor's license. And We did. We did. My whole crew. We did. We made sure that anything that we did would hold up in court, would hold up against a review, and was in the best interest of the patient. Okay, so let's go ahead and wind this down now. I do have an online insurance class. You're welcome to check it out. So that's one resource there. You can use the code BIOLAYS, and you'll get $75 off the cost. And you can find that information on my website. I did write a book called Moving Your Patients to Yes, Easy Insurance Conversations on Amazon, also on my website. You can order directly. I just sent out an order of 20 books to an office. The doctor is going to make a little, because it's not a thick book. It's good, easy reading. It's solid, but it's good, easy reading. And they're going to actually have a book club and use it for a discussion, which I thought was super cool. There is the CDT 24 code book, and that comes, if you buy the bundle, you get the CDT book, the coding companion, which gets thicker and thicker every year, and then an app. And I know lots of my insurance coordinator friends have that information right there on their phone or on their desktop. And it's almost like a little silent greeting between us insurance coordinators. And I'll say, who has the ADA app on their phone? And the people who raise their hands, I'm like, I know you guys are my people. So if any of you are out there with the app on your phone, shout out, right? I think it's fantastic. The other resource here is Fair Health Consumer, and that is where you can go to their site, fairhealthconsumer.org. You can go to their site and put in your procedure codes and your zip code. I think you can do 10 or 20 codes at a time, and then cookies get involved and all that. But you can find out where the percentile is. Are you at 75th percentile? Are you at 80th percentile? Some of you are going to find out that you're at a very low percentile and that you could go up in fees. As it pertains to revenue, my recommendation is raising your fees at least every year with the cost of living, in what it's called COLA, the cost of living adjustment. So if and it's set by the government every year, there's a cost of living adjustment. I need you to raise your fees for that. Your suppliers are going to raise fees, everything, supply chain, all of that kind of stuff goes up. And so we need to be competitive as well. And so definitely want to pay attention to whether or not your fees are competitive in your area. If you feel like listening to more of me, and on my podcast, I don't talk quite this fast. It's a little bit more fun and laid back, but my Nobody Told Me That is insurance and management. Chew on this as we we like to see it as the TMZ of dentistry. We talk about all sorts of funny, like TikTok trends and things that dentists do that are crazy, and office managers too. We pick on everybody. You're welcome to check that out. And then there is my contact information. If you scan that QR code, it takes you just directly to my website. So you can find more information, connect with me, social media, sign up for my newsletter, all of that good stuff. And again, I will post, or maybe if Joe could post in the chat again, that for any of you people that came a little bit later, maybe you didn't see the message, the link to download the handouts from all of this, all of these, the PDF of the slides. So you can go back and be like the super amazing person in your office that is going to blow them away with all of your insurance knowledge, right? All right, so let's move over here. I know that there are some questions here. Oh, 10 questions in Q&A. And I think, Joe, did you move over?
Teresa?
Yeah.
Yeah. So our audience has been super engaged and thrown some questions into the Q&A.
Okay.
That's always great to see. So, and thank you to our audience for that. I just wanted to point out, so we've gone about an hour. So I think in essence of time, let's look at maybe 5 to 10 minutes of addressing some of these questions, and then we can wrap up. So to our audience, if you can hang on for 5 to 10 more minutes, we'll address your questions and have some good dialogue about that, and then I will wrap up the webinar. You do get a CEU for this, so hang on, and I'll go through instructions on how you can get your CEU after we wrap up. Thanks, Teresa.
Thanks, Joe. And I see the link was popped into the chat. And if any of the questions that I wasn't able to answer, Joe usually sends me the questions, and I can go ahead and get that out to you. Yeah, so no worries there. Okay, so first question here. Courtney is asking, what do you suggest for cases when patients refuse updated radiographs? Are they a liability to keep as a patient? I just had a really good conversation with an office about this yesterday, actually. I'm sorry, on Tuesday. And I know tons of doctors. I think this really depends on the clinician's risk. Most doctors that have been in business a long time are going to say, you know what, I don't want this patient if they're not going to agree to let me use the tools that I have in order to make a correct diagnosis. Some doctors will say, well, look, if they don't want x-rays, then I'm going to document everything I can. I'm going to diagnose based on visual. And in my notes, I'm going to say patient refused radiographs. The lawyers are pretty, you know what, they are pretty no nonsense about this. They're saying, I can't defend you in court if you don't have any x-rays. And so that's going to be a problem. My preference, Courtney, and this is after years of dealing with patients, and sometimes you get a little bit less patient with patients over the time. I'm sure some of you have seen this happen. I'm not a fan of keeping a patient in our office if they are going to hamstring my doctor. Again, my job is to protect the practice and the doctor's license. So I think it does depend on the risk level of the doctor. I wish more doctors were less risky. It's what I'm going to say there. All right, Heather, the equivalent codes for Canada. I'm sorry, I don't, but call the Dental Society for your particular province, and they should be able to give you the list of codes. And if you're lucky, maybe somebody there is able to help you out with that. And I'm sure if you ask BioLays, because I know they have some Canadian reps, maybe that's something that Joe could give you a heads up on as well. Maybe they can put you in touch with somebody there. Okay.
For sure. And I'll give our education email here at the end so we can step in and help.
And then are we getting the slides with the recording? Yeah, you get the whole PDF of the slides. So you can use it. Wendy's asking, can the re-eval code be billed under hygienist? So all of the eval codes, unless you're in a state that allows it, all of the eval codes are actually supposed to be provided by the dentist. Now, it does the hygienist diagnose, you know, in the operatory and help them, you know, see big things for the diagnosis, of course. But it actually cannot be done by the hygienist only unless you're in a state that does allow that, and most states do not. So now, can it be billed can it be put onto the hygiene side where you're reevaluating the outcomes, the grading? Then yes, of course it can be done on that, but it has to actually go out and be billed under the dentist. Remember, the dentist information, the dentist notes for that evaluation must be in the clinical notes. Okay. For Anonymous is asking, lots of anonymous here. For LBR, could we use a consent form for the patient to sign like we do for upgrade material? We went over that, so I think hopefully that answered your question there. I'm not a fan of having them sign this because I have been on phone calls where the patient is irate, called the carrier, and the carriers are wise to this. They are wise to this. The carrier is trained to say, Mrs. Jones, do you know if you just revoke this, then they have to refund your money and they're going to have to write that off. And I have been on, I think I'm up to 6 phone calls now, where the patient basically revoked right there on the phone call. So I'm not a fan of using the consent form. And I know that this is tough to hear if you are in network, but that also makes me say to you, with respect and grace, if you find yourself in a situation where you are writing too much and this contract is not working for you, it is time as a business person to reevaluate any contracts that you're in, because this is business. This is a business cycle. A carrier will reevaluate their contract with you. And if they don't like what they see, they'll drop you. Same thing, landlord tenant. Maybe it's time to reassess your contracts and whether or not they're working for you. Okay, Sarah saying, I know you said you don't do medical billing, but do you have anything that can send me? Sarah, send me an email and I'll send you the list of names of people that I definitely refer to. And I'm feeling very, very confident when I give you those names. Something along the way here, can the patient choose not to bill things to their insurance? Absolutely. And that's what the HIPAA form is for. Where the HIPAA form came out was when HIPAA was created. I'll give you an example. If you are an alcoholic and you're seeking treatment for alcoholism, you may not want your employer to know that you're seeking this kind of treatment. And so that's where the HIPAA right to restrict disclosure form came. I'm asking the provider to not disclose that I have this condition, and I sign that form and I pay for everything out of pocket. So yeah, the patient can absolutely choose not to bill it to their insurance, but remember the caveats with any form, any HIPAA form. They have to pay the full fee at the time of service. You can't pick and choose which procedures, and the patient can revoke it at any time. And the reason that they're paying it at your full fee is because if you don't acknowledge insurance, then the insurance discount goes away. And now we're only talking about your full fees. Okay. So, Joe, I see a lot of other questions, but you're right. In the interest of time, we're already at 10 over. And oh my gosh, you guys you hung in there. I appreciate it. I'll go ahead and let you take it now, but I want, especially my East Coast people, thank you so much for hanging out with me and Joe tonight. I will make sure that you get the answers to these questions. He usually sends these to me pretty quickly. So give me about 48 hours to get that all out to you. Thank you. Thank you very much.
For sure. Thank you, Teresa. We definitely appreciate a lovely session. And to wrap up, just give me about a minute or two to our audience, and I'll give you instructions on how to get your CEU. Just a couple things before that, some activities that are going on within BIOLAs and the BIOLAs education world. Our big conference coming up is the Tequila and Tongue Ties Conference on April 19th and 20th in Miami, Florida. For more information about that really fun and informative event, you can go to tequilaandtongueties.com. If you want more information about BIOLAs education, including webinars, in-person instruction like hands-on courses or seminars, just go to BIOLAs.com, click on education, or go to education.biolase.com. Now, Teresa mentioned earlier in the session that we have a Waterlays billing and coding guide that Teresa helped us write, and we are updating this year. But if you would like to see the current version of that guide, go to resources. So go to biolase.com, click on resources, and you'll see billing as an option there, and you can look at acquiring that guide. Now, Waterlays Academy, if you are a Waterlays owner and you go to our education website, we have the Waterlays Academy, and that's really your home base for anything related to Waterlays education. We also have an Epic Diode area of the education site. So if you're a Diode user, you can go to that area, the Epic Diode Academy. Our next webinar coming up is with Dr. Fred Barnett on April 25th, an evidence-based overview of the mechanism and advantages of the Waterlays in endodontics. So it should be a really informative webinar focused on endo. So I'd encourage you to take a look at that. Okay, some instructions for you. So you must be officially registered to receive your CE, and attendance will be recorded via Zoom. Now, this is the most important part. You're going to get a survey via email within the next day. You must complete that survey to get your CE. Now, within that survey, we will include Teresa's Google Drive link. Okay, so within that email that you receive after the webinar wraps, we'll include that Google Drive link. So I did want to point that out, that you'll have another opportunity to take a look at some of Teresa's wonderful resources that she's willing to give you. Okay, so fill out that survey, and after you fill it out, you'll automatically receive your CE certificate. Again, this webinar was recorded, and if you would like to view the webinar at a later date, just go to biolase.com/webinars. If you have any questions for the education department here at BIOLAS, our email address is education@biolase.com. For example, the Canadian doctor that was on this evening, if you would like to be in contact with our Canadian representative, be happy to connect you if you just email us. And that is it. So Teresa, again, it was lovely to have you this evening. Informative as always. Thank you. To our audience, thanks for spending a little over an hour with us this evening, and we hope you can join us again on April 25th. I hope everyone takes care and has a great weekend that's coming up. Thank you very much.
Night.